Okay, this is a meeting of the two-tier research committee on a subcommittee of the board. It is the 13th of June at commencing the meeting at 33 minutes after 10 o'clock. And present is the subcommittee members, except for the board president, Kathy Disler, who is an ad hoc member of all committees. She's ill today and is not capable of being here. But Alex Leader, Chair Jeanette Bonaldi, and David Austin are the official members of the board. And this meeting is an ongoing research meeting that is collecting data as to the issue of the use of estheticians, both within the scope of practice and how estheticians maybe have been used or being used in the industry that are out of scope. Present today, and I'd like to introduce yourself, is
Susan Hilcher.
Okay, Susan, and you represent?
David just asked me to come and be available.
Now, what's your background?
I'm a physician's assistant and a healthcare attorney, and I teach ethics at Torrey University with the PA students.
So you would have views on how things are being run and how they should be run and whatever.
Sure.
And our other guest to be interviewed today by the subcommittee, so we can garner more information, is?
My name is Sandra Harvey. I'm a master's prepared nurse, and I work in private practice with Dr. Carl Williams, who is a plastic and reconstructive surgeon. I also am an instructor at University of Phoenix.
Okay, thank you. Madam Chair?
Thanks for coming today, ladies. I think what we're looking for is just your opinion on what's going on, and we appreciate your time. And if you'd like to start, I don't know if either one of you is in a hurry today. Someone would like to begin?
My secretary.
David, any suggestions?
Yeah, actually, Sandy, could you start by explaining the difference? Because Alex brought up a good point when he asked you for an LPN and RN. A lot of people don't know, because we have our licensing structure here, what the licensing structure is on the medical side.
Yeah, in nursing there is a little structure. We have the LPNs. We have the medical assistants that aren't governed by the nursing board, but you've got your LPNs, which is a licensed nurse. It's the lower level. Then you've got the registered nurse. And then you've got the advanced practice nurses. So that's kind of the three tiers that we have in nursing. And each of those different levels can take orders. Like an advanced practice nurse, she acts like a PA. So nursing then, regular nurses can take orders from that advanced practice nurse, and then the registered nurse can oversee an LPN.
Thank you. Okay.
And then
you're also an attorney?
Yeah. I don't practice here in the state of Nevada, but I have been a healthcare attorney, and I was predominantly in hospitals. And so I've credentialed lots of people, from physicians all the way down to estheticians who were in our wellness centers, our dermatology clinics, plastic surgery practices. So I do have some experience with that.
That's very interesting, because that's our biggest challenge at this point, is credentialing the estheticians. You said you had some sort of criteria you put them through, or how was that?
Well, usually we set, for all practitioners, you set a standard of whatever's required. Some of it, if they're employed, is by the employer, but the issue, I guess let me start with, in licensing or in regulating somebody, there's a kind of a hierarchy of credibility, and the gold standard is licensure, and that means regulated by the state, by the board, and usually requires some kind of demonstration of skills through a national exam or something else. Below that is the standard of, I made some notes, sorry, national boards or standards set by a national organization. And that's not considered as high a standard as licensure, but has credibility. And the bottom tier is continuing education, on-the-job training, that kind of thing. And so you set the standard for wherever the state law is, and then you can have standards above that as an employer. But for the state, the issue is, do you want to go with national board standards that are set, or do you want to move up to licensure? And I think that's what you all are looking at, is do the advanced group of practitioners need licensure and regulation by the board, or they just have a basic standard of licensure and advanced kind of training as kind of indicated by national boards or national standards?
Right, and I just think that's where the gray area is for us.
Absolutely.
What's going on in the industry today?
Well, here's the thing. Estheticians are starting to move more into an interface with medical practices, where they're doing things that interact more with healthcare, and they're moving more from salons to practices, and from clients to patients, and from treatments to procedures. And that's that advanced group. And so I think that people are starting to look at the procedures that they're doing and thinking of those more as kind of quasi-medical procedures. And that's why the issue of licensure is coming up, because that's what doctors favor, and that's what they look at when they look to credential people. Because you always have to have, no matter what you do in a hospital, doctors always weigh in on the credentialing of anyone touching a patient. Even if they were estheticians doing skincare like peels or facials or anything, that if they were in a hospital-attached clinic, the doctors wanted to kind of see what we were doing in terms of credentialing. At that time, we didn't have licensure beyond what is considered a basic licensure. But I noticed some of the states are moving towards the more advanced standards or advanced licensure.
I have a question. You've got, when we talk a lot about these things, one of the things that from a medical standpoint, what our concerns are is who's governing the medical spas. Mm-hmm. Should there be certain procedures that are only done in physicians' offices where the physician is present? Or can people just go out and start their own little businesses in these medical spas and have a physician's name or a DO's name or a chiropractor's name as the overseer person, you know? One of the things in nursing, what has transpired recently, I did some research knowing I was coming to this meeting, because we have quite a bit of information on our state board's website. And there's always been the question within nursing as to what can nurses do. Unfortunately, Dr. Williams and I tend to not agree with some of the ways that the nursing board went. However, what they have done is they have rules and regulations that pertain to a practitioner, a nurse that gives injections. But what they've recently done is they've developed a national test, and they've made these, just like a lot of other individual nursing credentials, they have, tried to encourage nurses that are in this field to belong to this society and take this national exam. And then what they did is that nurses that are certified through this board or this committee, they have regulations more lenient versus nurses that haven't taken this exam or belong to this society. So currently nurses right now, they have to be overseen by a PA or a nurse practitioner who would do the evaluation of the patient, history and physical. I mean, it's, a detailed exam, and then they would make the recommendations or the orders for those injectables. So you can't just go in somewhere and say, I want 40 units of Botox, and she goes to the refrigerator and pulls out 40 units of Botox and gives it to a patient. They can only do that if either they belong to the society and are certified, or somebody higher has seen the patient and done an evaluation.
Question. I'm sorry.
And those are for nurses.
Yes.
Just a real quick question. Because my understanding is prior that below a PA or a nurse practitioner, you cannot diagnose.
You cannot diagnose.
Correct.
You cannot
So
diagnose.
you understand that they
Right.
can't diagnose. And here's an argument, I guess, playing devil's advocate. Now, you go to actually win with Lewis Ling that time.
Yes.
And I said, well, if Allergon, who makes Botox,
Right.
it advertises, says Botox cosmetic, it's taking care of wrinkles. So are wrinkles a medical condition you're diagnosing, or just a condition of aging, which is not a diagnostic situation? So it gets into a...
I know.
Well, but a deep rhyotide is going to be, that's what your diagnosis will be. You'll
Right.
either have a surface fine line or you have a deep rhyotide that will, but it's still what you're saying is that higher tier makes that diagnosis
Right.
and then instructs someone else.
Right.
And I wanted to get
Right.
back to what you had said earlier, which is you're finding that it's the advanced technicians that want to interface with the medical practice. And
Right.
I'm going to actually disagree with you. I think it's the new licensee coming out of school that wants to go into a medical practice
I agree.
to gain some experience,
agree.
to then figure out how can I go into my own
Home business.
practice
Exactly. I
and
agree.
utilize the skills that I've just
Right.
learned.
Well, and that the piece that's coming up on the legal side is that interface with the medical profession, and you're starting to edge up to what constitutes the practice of medicine. That's
Yep.
that's where the advanced practice esthetician license comes from, is because it was to say this doesn't constitute the practice of medicine and this does.
Yeah,
And they were
I agree.
closer and closer to the line. And so
Right.
that's what, I agree with you, probably the new student is looking at it differently, but for the advanced people, they're running up close to what physicians are saying is the practice of medicine. And that's the line that everybody's trying to find.
Here's one of the things
Cross.
that we're seeing.
Yeah.
We're seeing in the field. We have estheticians that there's a clear regulation as to how and what they can do and where they can do it. They move over to a medi-spa. Now, there's no doctor present. The
Right.
doctor is elsewhere. This is
Right.
one of three, and there is no doctor present. And that esthetician says, I want to be doing the injections and everything else, and there's no supervision, direct supervision. So they can't work under our license under those conditions.
Right.
Even if the doctor's present, if they do anything outside of the scope, they can't work, they can't do those services because they're not authorized by us. So then what we hear back is the doctor has trained them and therefore takes responsibility for the services they offer. Now here's what happened the other day, well, about 3 weeks ago. We had investigated a medi-spa in the western side of town that we believed that the esthetician was working out of class. We made them get a license for the room in which the esthetician worked, and made them get the esthetician had to be licensed for that site. Then the board of pharmacy shows up and says, by the way, there's no doctor on the site who's authorized to give that medication or those materials. So they're in violation of another regulation. But it's the same problem because these people are assuming because a doctor owns the building that they have the right to do these other services. So the issue for us is, where do we draw our line? Do we do, and I've been thinking about this, I haven't had a chance to write it up, but do we do an enhancement or an endorsement that says those people with this extra training, as you described, at the National Training for Nurses and whatever, and if they have that training, we would endorse their license that they could be legally capable of doing those kind of services because they're properly trained and certificated? Or do we invent a new license or a secondary license that we take responsibility for, which includes that kind of training that has to be taught somewhere? So we're caught in this process. Where do we land on our own feet? The problem I'm having is the nursing board took action, but it didn't really solve the problem. The board of medical examiners were forced into taking action, but it didn't solve the problem.
Made it more vague.
And we're totally
Right.
lost trying to figure out where do we draw our line.
Right.
And Nevada does something kind of that I'd not seen before, which is the medical assistant category is kind of on-the-job training,
Yes.
whatever the doctor
Yes.
allows
Yes.
you to
But
do.
there are schools that charge exorbitant fees.
Sure, but I think what estheticians and doctors are thinking is,
Yep.
well, you're operating
Yep.
as a medical assistant
Assistant
while
assistant.
you're doing this.
An MA, that's right.
And then you're an esthetician when you're over here in your room doing these certain,
Yeah,
treatments.
that's exactly what's going on.
Yeah.
But do we see MAs injecting Botox and fillers?
Mm-hmm.
We
Yeah.
do.
Mm-hmm.
Yeah.
Yeah, and that's the problem.
I think once you've been trained, you want to continue that skill set, whether I'm working for you or for her or for on my own.
Yeah.
That's what I feel we're encountering. The other thing that I feel is really really part of this subject is that the doctor sees that the esthetician has a license, so there's an assumption of my advanced skill set.
Yeah.
When the reality of it is the license is representing the minimum standard for the licensure. So
Yeah.
really, you've got physicians that want to hire the licensed esthetician because it somehow says that we've met that gold standard, when really we may not have that appropriate skill set or could not be appropriately
But just
trained.
because you have a license doesn't mean that
Right.
you can do it. I mean, I also
Right.
was
There's
in
that
respiratory
perception.
Right.
before, but I like what you're saying, and that's where I come from with my beliefs, and the same as Dr. Williams, is practicing medicine. And I think with the nursing, what nursing has tried to do in a roundabout way is with the advanced practice nurse who it acts like a PA.
Sure.
You are practicing medicine by doing that evaluation of the patient. Estheticians don't have that knowledge or that background. The other thing you've got to think about is when physicians think about when you're injecting things into the face, who's going to deal with the complications? Your esthetician can't deal with the complications, and there's some horrendous complications. They may not be high rate, but they do happen.
Well, and that's usually what prompts some kind of licensure problem, is that somebody dies,
Yeah.
and in a number of states that's what's happened, even to PAs. If we do something and it goes badly, the Board of Medicine can turn around and say, no PAs in the state can ever do that again. And you're powerless because they take it over as the practice of medicine. And so I think what you all are doing is very timely, is trying to define the limits of your licensure, so you don't have the Board of Medicine say, half of what you're doing is the practice of medicine, stop
Right.
it. Because then you're really in trouble, and it doesn't matter what your skill set is. They're going to take it back, and they really have the ability to do that. It's hard for any profession to fight them.
I don't have any resistance, and we talked about this at the last meeting, and I'm not an esthetician, I'm not a cosmetologist, I'm not a medical person, I'm an administrator, so I look at it from administrating things, is that I don't have a problem if we can come to agreement with the nursing board and the medical board and the cosmetology board of drawing the line and said, if the training, basic cosmetology services, aesthetics, that's a standard license. I don't have any problem if our board decides, with agreement of these other two boards, as to where we draw the line and what kind of training would be required, is to set forth that in a endorsement of a license or a secondary license. The issue is finding that middle ground that stays away from medical procedures that they shouldn't be involved, because that's what I see happening.
Right.
Yeah.
I'm not saying all doctors are doing it, but there's a few
Right,
that says,
sure.
well, I gave them 2 hours of training, that should be enough. And I was asking the ophthalmologist I go to, because they have a lot of MAs, but they have 20-hour training programs that they all must pass, and every machine has to be, you got to
Right.
get a high enough score that you can say you can do it. And those are just using machines to check, your eye acuity and stuff.
Right.
But when you start injecting
Right.
and you're doing the manipulation of certain muscles and tissues, then I worry. So we haven't been able to find the middle ground. And it all started with that problem with, David, do you remember what that started with? It was an inspection of a particular medical spa or something.
Yeah.
So anyway, that's
the
what
rest.
keyed my interest in it, and I kept going to the Board of Medical Examiners to see what they're going to do about it. I've been monitoring the nursing board, but I don't see a real resolution for us yet.
Do you know part of the problem is public perception?
Yes.
Because let me bring up.
And Allergan, you made a good point about Allergan.
Well, when you look
too.
at their ads in the paper, even on the
the
commercials on TV,
magazines,
Allergan,
right.
it's Botox Cosmetic. You guys remember a few weeks back on the news, and it was for over a couple of days. There was a woman up in San Francisco who put her little girl beauty pageant injecting with
8-year-old.
Botox.
Oh, yeah. What?
You didn't hear about this?
No.
A few weeks
Yeah.
ago. The social service took the kid away. I don't know if they gave the kid
You
back.
think?
She was giving her Botox. Well, she wanted it. She didn't want. The kid was. I saw the woman on the news. Well, how did you get it? Well, I'm an esthetician.
Yeah.
She saw that she said she's an esthetician. Turns out she's not even an esthetician. Apparently she lied about that. But she was under the belief that estheticians can inject. That's why she said it.
That's what she said, yeah.
Yeah.
Perception was she could do it.
Yeah.
And actually, I've had recently at the salon at Town Square, somebody came in, we had an esthetician there, and they said, how much is Botox? And I was standing up there and said, we don't have Botox. You don't? They said, we don't have a doctor here. We have an esthetician. I said, they cannot inject Botox. You have to be in a medical environment. Oh, really?
But actually, it's not just injectables. Like we have dermaplaning is a big
Right.
one.
Sure.
Right.
Oh,
Like
yeah.
right
Healing.
now in northern Nevada, we've got estheticians that are in their own private practice that want a dermaplane. Well, the key to that is you're using a scalpel.
Yeah.
So right off the bat, you should know that you're kind of outside the scope of your practice. So I guess to
That's
kind of
scary.
bring it in, you know, I just also wanted to maybe stop and may have Lori. I'm so sorry. Rosemary, thank you. Just welcome both of them too, because Lori is a manager for a school. And are you also with the school?
No, I'm with Milan Institute of Cosmetology in Reno.
So you're also
I'm a
associated
teacher.
with the school.
Yes.
And so really, that's the first line of defense that you have for our industry, which is that the school can tell you what your scope of practice is going to be. But then once you're licensed, that's where it's the licensee that
Yeah.
wants to kind of attest the boundaries of that licensure. And I agree with what you had said earlier, which is that at some point you're doing MA work, and then at like Tuesday, Thursdays, and Monday, Wednesdays, and Fridays you're doing aesthetics work. And that was exactly what my situation was. I worked for a doctor, so when I assisted her in the room, I was acting as her MA. And then when I did a chemical peel in my own room, I was acting as an esthetician, even under the scope of her license. So even though I was acting as a licensed esthetician, I was doing work that was still underneath the physician's license.
I think.
So,
I'm sorry.
well, I was just going to say that the boundaries were very skewed and
Sure.
not very
No
clearly
clarity.
delineated at all.
Well, and I think what's probably concerning to estheticians is if they're operating as an MA, they can do more than they can under their esthetician license, which to me
But that's
seems
because
upside
they
down.
are under the physician's license when they're in that office.
That's correct.
Right.
Supposedly.
Right.
Right.
Right. So, and they're under his malpractice.
And those companies, because I have a friend who's a malpractice attorney for insurance
Yeah.
companies. That's what he does. And he said they're watching very carefully, waiting, because they know
Yeah.
that somebody's
Well,
going to
the
wear
example I gave a few moments ago about not having a proper physician to dispense certain chemicals that are restricted, that was a gynecologist whose main office was in Henderson, never came to the office,
Right.
Yeah.
and that they were dispensing
Yeah.
restricted chemicals or
Yeah.
drugs. And so those are issues that we see as troubling to us. And the concerns we have is where should we land? Now, there's a great desire for expansion of the profession of cosmetology, because everybody wants to do that. The trouble is it may or may not be conducive to the environment they have to live within, and does that put us at a liability if we don't either sanction or not sanction it properly? So the legal issues that I see come through on those issues is where do we stand? So from your perspective, you're represent the nursing board or nursing profession.
and, yeah,
So where do you
nursing.
think it should land?
I think, honestly, and I speak not only for myself but for Dr. Williams, I think that when it comes down to injectables, it should be with the medical profession. It's not. You're not taught that in school as an esthetician or a hairdresser or nail person, that's totally outside of your scope, injectables. You don't see estheticians just offering flu shots.
But really, it's all medical procedures. I mean, I think injectables is just one aspect of a medical procedure, because you said it earlier, which is you've got the medical procedure comes from the diagnosis. So once you have a series, like I even feel like the intramuscular shots, where you're putting Kenalog into the buttocks or something to help with a rash. I mean, even that should be a medical.
Well, it is, but
provider.
as a medical provider, we can do those things, but not as an esthetician.
Right.
You can't do those
But
things.
remember, in our profession, it's not just estheticians. Cosmetologists
cosmetology
can do aesthetics. Cosmetologists are licensed as estheticians.
But don't you also have a license designation between people that do nails and hair?
Sure, correct.
Right.
So,
but estheticians, you can still do nails and skin when you are a cosmetologist.
sure.
See, that's where a lot of the discrepancy comes in.
Yeah, no, I think what she's trying to say is...
a cosmetologist is an all-encompassing.
Right.
Right.
Where,
well, same with
She
as
stated
a
that,
nurse.
and she was
as
breaking
a
it
fully
apart
registered
correctly.
nurse.
Yeah.
Right.
But then, if I want to specialize in OB, then I kind of go off that way, and I have extra training that way. Or if I want to go into pulmonary and respiratory, I go up.
We have where you can only do nails, only do skin, or only do hair.
Right. We don't
And then
have,
they have
we
the
don't have
umbrella of
that.
the cosmetology.
But I think when I understand what you're saying about, but those are not facials and other things that estheticians do are not things that are taught in nursing school. They're not things that are taught in the physician school, DO school, wherever. So you may consider them as a medical type practice, but they're not found in the medical realm. But injectables, they are, and they can cause complications which you need medical intervention for. Now, the other thing I was going to ask you is malpractice. What does your malpractice license regulators say?
We don't have a malpractice.
Well, it's
provision.
clouded because we're all under the doctor's
Always.
scope of malpractice.
Yeah,
when you're
in
in their office.
cosmetology, you're just standard insurance policies for liability and stuff
Because
like
they're,
that.
when I
Not
got
like doctors that have malpractice insurance
right.
specifically.
So when I get doctor's malpractice, which I was really shocked to see, because doctor is boarded in ENT, plastics and reconstruction, and hand, okay? And he's been in practice for 20 years. He has probably in his 20 years, maybe 5 cases that were settled out of court for just weird things. But when I got his malpractice this year, it says he is not allowed to dispense or order or prescribe HCG. I thought that was really strange.
It's a diet.
Yeah.
So you cannot get HCG from our office. And I haven't had a chance to call, to find out where did that come from, but that was the first time I ever saw that. So I know HCG is on the hot plate right now. But that was written in the malpractice.
Well, malpractice carriers drive a lot of what doctors can do or don't do.
Exactly.
When I was dealing with doctors, that was the fastest way to get them to stop something, is say, is this covered by your malpractice carrier? And they would be like, oops. They hadn't asked.
Yeah.
And a lot of times they would find out not so much. So, and I do think malpractice carriers are probably really concerned that medical assistants or estheticians are doing stuff that's beyond the scope of practice, because the doctor is going to get sued for malpractice, but he's also going to get sued for negligent supervision, which is just another charge. And it just hasn't happened yet.
And that's what I'm sensing is the doctors in Nevada have not really lost the big suit yet.
Right.
They haven't been sued for $2 million and had to pay $1.5 million for the big suit. I come from law enforcement, so I used to get sued all the time. I understood all the rules.
Yeah.
And that's my concern is that some of the doctors we run into, many of them are fine, absolutely great physicians. They have their priorities down right, but some aren't.
Right.
And we don't have any control over any of that. But they're snapping up our estheticians who think they're in great environment and they're at high risk.
Yeah.
We concern ourselves as what should we be doing to make sure that either one of 2 or 3 things are occurring. I don't have any problem with being a feeder industry. In other words, we can say we can build this second tier or whatever the enhancement or endorsement letter looks like that says if you have this training, then we have no objection to you working for a doctor and doing injectables even with our license available, certification. I don't want to do that though if we can't force the issue between us and the Board of Medical Examiners or the nursing board to say these are acceptable to us. So we all know how it's going to operate. We're waiting really for the other 2 agencies to react so we can then line up properly.
Well, usually how it comes is if in Utah and Virginia's law it says these things do not constitute the practice of medicine. It's written into the law. And the Board of Medicine agreed that these carved out procedures were allowed to advanced estheticians.
And they're not medical procedures.
They are not considered
And that
medical
allows us
procedures.
the ability to say we can either adopt them or not adopt them. Because
Right.
they took that action.
Right, and you can grant it to certain people who meet certain
Certain
standards
criteria
and
that you
not
set for it,
everybody.
yeah.
I think one of the biggest problems is that estheticians don't know what the risk is. And the risk to the physician is malpractice. The risk to the esthetician is you lose your license and your ability to practice. Because that's usually what happens when they go outside of their scope of practice and they're considered to be practicing medicine. It's a felony, and it just rains down all kinds of problems on the person who's doing it. The doctor doesn't get in nearly as much trouble as the person who's outside their scope of practice. And that's the problem for the people who are
That's
doing
what I
it.
say too.
Yeah.
Yeah, well, I was just going to say, too, if you look at what's going on in Nevada, I don't know about the other states, I just know that it is rampant amongst everybody. But just in Nevada, just like you mentioned a while ago, there are physicians out there that just buy the stuff and, have
Hand it
people
Yeah.
doing it.
Yeah.
So if you want to protect your estheticians, really in physician world, these physicians that are ordering all of these chemicals, they're supposed to be specially trained. But how you can't, the Board of Medicine can't govern a chiropractor or a DO, so you've got every physician out there just saying, oh yeah, I'll buy it, and I'll just, have them, like the medical spa, they'll just start doing all these injectables, and then they get a percentage off the back end. And the more they buy from Allergan, the more they get back from Allergan. I mean, they get monies from Allergan.
Yeah.
And
volume discounts.
Exactly, and volume discounts. So it becomes then, a bad thing with some of these physicians out there that want to make a little extra money. And like you said, Allergan or these other big companies, because they aren't protecting the public.
People things like teeth whitening.
Exactly.
Yeah.
Exactly.
Now, I was under the impression that the nursing board was moving in a direction where only nurses and physicians could inject. Like, that they don't even want the MAs to inject anymore.
Oh.
That the nurses were saying, hey, this is a skill set that we've
Right,
earned,
right.
and we're not giving it up.
Right.
And so, with that in mind, it would seem to me like...
Let me just interrupt one thing. You won't find a lot of RNs in private practice because physicians cannot afford them.
Right.
So, like I'm a rarity, but all of my other cohorts, physician cohorts, now they're looking at perhaps, they don't even want a nurse practitioner because they feel even a nurse practitioner is going to be too expensive, but they're looking at getting PAs because there's a lot of insurances that will pay for a PA. Insurances do not pay for nurses, okay? And a nurse practitioner actually has a lot more education than a PA does, and so they usually get a lot more money but when you're looking at private practice, or even a practice that's got 3 or 4 physicians in it, you can't afford that type of an advanced practitioner.
Now, I thought that the nursing board, though, was also trying to stand up to that and saying that all private practices had to have one RN on staff.
They're not going to ever be able to tell a physician you have to have an
Yeah,
RN.
that didn't fly.
Oh,
Yeah.
oh, it didn't go. Oh, I thought.
Now, what we saw as a settlement is what you guys are used to, and that is the regulations were changed slightly. And she described it earlier about a certain amount of training has to be if you're going to use injectables.
Right.
And so that's about as far as they got. They haven't dealt with the more nitty-gritty levels yet.
Well, and the issue really came up for things like flu shots and,
That's what
and
brought it up.
B12 and
Yeah,
stuff.
yeah.
The most basic shots. It wasn't up at the Botox and,
Right.
and
Yeah.
injecting other more dangerous
The argument actually started with a flu shot
Yeah.
concern when this came to the table. The Department of Health got concerned about how do we dispense flu shots. So they had to clarify the issue. So now they've settled on this training issue that is acceptable for anybody who's doing flu shots or other injectables. But that doesn't really address the issue that David and I saw when he was chairman of the board, and that was the use of estheticians as MAs with minimal amounts of training. And the doctors were saying, some doctors were saying, well, they're under my supervision, so I have the right to do that. That may be true, but we wouldn't allow our estheticians to actually work under our license. They worked under the doctor's license, under their malpractice, and anything that happened is under your problem. But if they were doing services strictly as an esthetician and they were advertising and stuff, then we would have control over their license. We could take it if we wanted. That's one of the problems. The issue is, do we develop a hardline position on our license and say that's it, and maybe that's the best legal position to take, or do we flex a little bit if we can get cooperation of the other two agencies that really regulate it? And we see the same thing with, by the way, with podiatrists. They want to open their own podiatry services. It's called some kind of foot spa or something. And they don't want to be licensed. They're working under the determination of the doctor's license. We've put a stop to that whenever we've seen it. We've said it has to be separated, it's got to be advertised, they better be licensed, because we're not going to allow it. And they've acquiesced. But that's purely I would call it just a muscle game. I'm say you want all this trouble, I'll create it for you, because we don't believe you're doing it right. But there's not really clarity even on that.
What has the Board of Medicine said, or are they just letting their doctors do whatever they want?
That's my interpretation as a lay person, is they don't want to address the more complex issue because most of the members of the board are doctors, and it's a political issue, and it has to do with follow the money. In other words, if you want to cut off some of the revenue streams, you take a hard line. They don't want to touch that. So the pressure is, we don't want to deal with it, so they've avoided it. So the issue leaves us hanging constantly.
Do you remember when, right before the legislation last year, when the proposed definition of an MA?
Yeah.
So we're up in Reno, and I called over to the Board of Medical Examiners, I think the day of our first subcommittee meeting, and talked to the deputy director, who's the one who handles all the legislative stuff. And because I read on there, an MA is a person the doctor deems qualified. Any procedures doctor feels deems they're qualified to do, can do in the doctors. And I said to him, it seems awfully vague, and his response to me is, yeah, it is.
It's done on purpose.
Yeah.
Because of the backlash.
Here's the downfall of this. What I see, if you're talking about just the PR issue, is what's going to happen is there's going to be the big lawsuit. And they're going to find out estheticians have been doing these things, whatever these bad things are. And they're going to blame you all.
Yeah.
They're not going to say the Board of Medicine should have defined. It's going to be here.
Well, it's going to be on the estheticians.
Yeah.
It won't even be on the Board of Cosmetology. It'll be on the estheticians.
I think she's right. I think it'll come back to lay at our footsteps.
Yeah.
Especially
our
if they
doorstep.
find out if a third of the profession is doing it. They'll
Right.
say, you all need to really,
Do something about it.
yeah.
And the problem is we tend to look at the problem from different angles because it's so uncomfortable to look at it from the proper angles, is what the cosmetic surgeons want, what the medi-spas want, and they're all money-oriented industries. And when we put a stop to that, much like the dialogue about the surety bond issue, it is going to come back to be a major tumultuous process because nobody wants to give that up. And the problem is until somebody dies or is there's a major catastrophe that it becomes an embarrassment, much like the endoscopy system.
Yes.
That told me that they weren't doing the job. Somebody wasn't doing the job. And now it's gotten to be a major issue. And if people go into jail, people are are infected. And until it comes to that, nobody's going to pay attention.
Right.
We're trying to get ahead of that a little bit. We don't know where we belong completely. We're really interested in your opinions as to what you see. I know the nursing group has a particular point of view, and it's good that they do. You have a unique perspective because you see it from the illegal angle, and that's what I can usually identify with. But you were involved in the business, so you understand what they're doing and what's flaky and what's not flaky. So it really is helpful to get feedback from both of you. And I want to be able to get back to you when I figure out what we all said, what it means, so I can understand what you really meant by it.
Well, can I make a suggestion? I would start your CYA action right now if I were you, which is start to clarify, start to define some things without totally offending physicians, but also a formal letter to the medical board presenting this is going on. It's somewhat of a problem. So when there's blowback, that letter and some other things can come out that we were trying to address this, but it really is what constitutes the practice of medicine, and that's not something we can define. And I think, because you know it's going to come, you know there's going to be something, and you can say we did our best to ask the other boards to do their job and to handle this, rather than looking at the cosmetology board and the estheticians were running amok, which is what the other boards will say.
Yeah, and I see that's really where I'm going.
Yeah.
Is I want this group. I'm getting ready for the battle, so I'm building the record, the path, the paper trail. And the issue here is we got to figure out what we are, first of all. Once we figure out where we are, and if there's option 1, option 2, option 3, as alternatives that we might implement later, then the next step is to formally meet with those boards and say, we have a concern, we need to talk about it. And they're probably going to tell us go to hell. That's what I think they're going to tell. But a formal letter saying we'd like to meet on this topic, we're trying to establish a consensus of where the line or the scope of practice end and where medical practice starts, and how the supervision requirements for these kind of individuals, which are under our control, are done by your side, who are under your control. What is the parameters? What are the requirements? Laying out what they believe is medical practice, what isn't. And then that starts to protect us in the major trial that will come along, or blaming. But the public relations, the concern I have really, is endoscopy had a phenomenal cooling effect on the medical facilities in the state of Nevada. I was thinking about my own personal view of stuff. I came out of California, out of the Kaiser system, large, but it was very competent, that kind of thing. And I'm thinking to myself, do I even want to go to a doctor?
I know.
That's where I came from. It destroyed my confidence.
Yes.
And I'm worried about destroying the confidence of the cosmetology industry, because that'll kill the industry.
Well, there's been one and a situation, and Chris up in Reno, who's an attorney, represents the insurance company. There was a case not too long ago, somebody's hair removal was just totally burnt, really bad. I'm not going to know the detail on it, but I believe it was an esthetician, was working as an MA in a doctor's office. They tried to get out of paying by saying, the person's not, but the technical information, I guess, it was under the doctors, so they had to pay, because under the doctor's malpractice. So in turn, what they're rewriting the writers and everything a little bit, adjusting. Just like you said, there's a thing about NOAA, HCG. So they're probably adjusting what.
Well, I know my own E&O carrier doesn't permit me to use IPL in my shop, so it's a specific exclusion on my E&O. But one of the things I wanted to get back to you is Vince is covering a really good point. And I'm just going to make a kind of a transition to it, which is right now our law prohibits estheticians or anybody who's licensed under our board from calling themselves medical or advanced. But what I've noticed in the marketplace is that there's a medical aesthetics business that then registers you upon completion. So now you can advertise yourself as a registered medical esthetician. So on one hand, we've prohibited it, and you can't be a medical esthetician, and yet we're allowing registered medical
That's the same
estheticians.
thing that's going on in physicians. Board certified.
Right.
What is board certified?
Right.
The public has no clue. If you have a certificate hanging on the wall that you went to a 3-day course on abdominoplasty, you're board certified. They don't know about the American Board of Medical Specialties,
Right.
where there's only X amount of medical specialties. So it goes along with the same thing. What does that mean? And it
Right.
goes back to what David was saying about the marketing. The marketing out there, I mean, I can ask anybody, what, is your doctor board certified? Oh yeah, he's got a certificate on his wall.
Yeah.
Certificate from where?
Right. It's not the same.
Right.
From, Disneyland?
Right. I agree.
They don't know. So some of it comes back down to we need to get out there and do a lot more public awareness and patient education. When patients come into my office as plastic surgery, well, as cosmetic surgery, it's a whole different ballpark than when I'm on my medical hat, because when they come in as plastics, they want a used car salesman. They want to say, well, I can go down the street for this price. I say, no, let's back it up, and we're going to do some education here. And I really don't care if I lose that patient, because they can go to Mr. D.O. down the street that took a weekend course for abdominoplasty. If you want to risk your life for $1,000 difference in price,
Go ahead.
go for it,
Exactly.
And that just
People
really
don't
makes,
know.
they
You
don't.
raised the valid point. I've not seen the registered.
No, I
It's usually
mean-
the word certified.
Yeah.
That's another one,
Yeah,
because
there's
they
a
have a
registered.
certificate.
Yeah.
And,
There's registered and certified medical estheticians, and we don't allow that. So I don't understand how that's taking place.
Under our laws, we refuse to allow them to do that.
Right.
And if they're not operating under our license, they're using the doctor's cover, but they're calling themselves whatever they want, and we have no way to stop that because we no longer control their license.
But I was kind of thinking what you were saying earlier about starting that CYA, which is David, you brought this up, is owning the word esthetician. Because once the Board of Cosmetology says, hey, if you're saying you're an esthetician, then you're governed by our board. So whether you start to deviate and call yourself registered, certified, advanced, this or that, medical,
What do you-
if as soon as you use that esthetician, that's when it all kind of comes back to...
How do
that's
you
what some professions have. Do you all have, if someone violates your licensure, what can you do to
Well,
them?
we can pull their license.
Okay, but someone who is using the word esthetician,
Yeah,
just
no,
like
right.
you can't use the word physician as a PA. I can't say I'm a doctor.
We own the phrase, you can't advertise as a medical esthetician.
I guess what I mean to say when I say own it, I mean own it.
Yeah, you're talking
Well,
about,
yeah,
it
but
cannot
I'm
be used
saying
in the
legally.
medical field as esthetician,
Yeah.
Okay, so
aesthetic.
when they're
work.
using medical
But
aesthetics,
they are.
aesthetics is a general
But
term,
they
but
are.
esthetician specific. It's
That's how they
medical
get around
aesthetics. Really, you think about, okay, I'm being very, it makes,
I
okay, think about
understand that.
it. Okay, medical aesthetics does fall under what you guys do. Plastic surgery, aesthetic, medical aesthetics.
Right.
So, let's say you took,
Yeah.
well, some of what you, let's say you were doing some dermaplaning and some of that stuff. That's medical aesthetics. You're,
Right.
you're a medical
Yeah,
professional.
and they're qualified to
And
do it.
an esthetician,
Right.
They're not
Yes.
qualified.
They're
not
not
qualified.
qualified.
Yeah.
So that's one of our dilemmas, is how to own the thing.
the
We
word
can't-
esthetician.
Yeah.
And so that's hard to get defining. We've already defined you can't say you're an advanced or medical esthetician because there's no such license or category that the board authorizes.
But some of the doctors, one of them I looked on their website.
But
under
they
the
advertise
employment-
all the time.
But if you look in their employment section on there, what they're hiring for the medical spot, one of them, their positions is medical esthetician, and they require Nevada State license in the State Board of Cosmetology.
to see real complicated.
Oh.
You know, like it's kind of the same thing with physician's assistants. I
Yeah.
thought, which was even a physician's assistant always has to have an on-site physician.
No, it doesn't have to be
no.
on site.
It's not
It has-
always on site.
It's not
Okay.
always on site, but we always have to have a supervising physician, and there are rules for that supervision.
how-
They have
how
to
they-
review so much, they have to be available, that kind of thing. They don't have to necessarily be directly on site,
I think
but
And
you
you
can
don't-
supervise, and the PA can supervise
others.
others.
And you don't necessarily see that tightening. Like you kind of, if anything, that might loosen even a little bit more. In other words, as the physician, I might be able to be 30 miles away today, but in a year's time, I might be able to be 60 miles away.
Well, usually the board sets that. It's in laws or it's in regulations what a PA can do and how many PAs that a physician can supervise.
Supervise.
Every state has that.
Right.
Okay.
And so it's more and more, it's pretty clearly defined what that means. You can operate in a remote clinic and things like that, but they have to be, there's a line to the physician of what they have to do. And even advanced practice nurses
Right.
often have,
They do.
you know, supervising limits of what's required.
So that's something that's kind of missing in our component. We don't really have a component of a supervisor. When we look at our licensing, we are our own supervisor.
Oh, good point.
So that's an area that we haven't really explored
Well,
as
the
a
issue is,
committee.
well, I'm comfortable
I was gonna say,
internally.
you do have
You have to have a
have-
licensee in charge.
Yeah,
Regular.
we do have that internally within
Okay.
the scope of practice when you're working within the scope and you're within a licensed facility. Those all make sense to us. It's when they move from our territory
Right.
into another territory using somebody else's cover as the legitimacy. That's where it gets real gray in the middle there. So what we're trying to do is define that with the agreement of these other boards that would be affected by it, and maybe even podiatry board would be included. But they say, yes, that's logical to us, and if you bring your line up to that place, we will have finished the other side. That is, the other side is not finished. There's no definition. They say, when I look at medical assistant, I mean, that can be damn near anything.
It can be.
And so there's no way of pinning that much down.
Is your physician interested in hiring an esthetician so he can offset some of
No.
your responsibilities?
His,
or-
unfortunately, he has had estheticians in the past, but they've left, and then when they leave, they take his clientele. You know, he just doesn't see. You know, that's just not. He's not big into aesthetic type stuff. He's more into surgery type stuff.
Now, do you see, not your physician, but do you see other physicians wanting that?
Oh, sure.
Yeah.
Oh, when we go to, we're active in the societies. Absolutely, absolutely. But in our the Plastic Surgery Society for Nurses, that's their big thing, is doing the job of the esthetician in the physician's office as a nurse.
Now, we have, the aesthetics has a society too. It's called, you might know. Well, it's not Sedesco, it's
It's on the
the,
NAC.
yeah, it's the SESS, which is the Society of Skincare Specialists. And so it's the same one as the NCEA. It's the little offshoot of the NCEA, which is the National Certifying Aesthetics Association. And then she has another one called this kind of skincare specialist. I don't really know exactly what it is, but it seems like that agenda is what you're talking about. That you have this society where they want to expand that scope of practice for the esthetician who goes into the plastic surgeon office. They want to be able to have that expansive
Personally, I
job
think
skill.
it's a great thing because they are doing advanced education. They do have a formed curriculum which could be very helpful in a doctor's office.
But the other thing I see where it is a lot more than in plastic surgeons' offices is in derm's offices, dermatology.
General derm.
Right.
I remember before I was actually licensed years ago in California, there was a thing on the news they were trying to change. They were called actually cosmeticians. Cosmetologists. Do you remember that cosmetician? And there was an argument because they wanted to change it to an esthetician, and the legislature in California at the time wouldn't do it because they felt it sounded like they were too medical.
What
So-
if times changed?
Understanding these kind of issues from your perspective, you got both the legal and practitioners level. What do you think? Where do you think we should land, other than covering our fannies? That part is a good one. I like that part.
Yeah.
I was sitting here as you all were talking and wondering if the advanced license fixes some of this.
Oh.
I don't know. I think that's a question worth looking into. Does that give people the ability to do more things so physicians would be inclined to go with those people? Or does it just make it worse? That
Well, I think what
And
happens is that it makes us kind of quasi-medical. Like, I feel like the Board of Cosmetology is focused on beauty, and medical is focused on medical. And to find that bridge between the two, yes, some of those employees are going to bounce back and forth. And the way that it's happening now is physicians want to hone day spas. And then the way that it bounces the other way is that now that you own this day spa, let me come work for you. So I feel like it's already kind of gray, but I really don't want to see, well, particularly new licensees doing these quasi-medical procedures. I just think that it's a real blur of medical. I would think that medical would want to rein in what they do medically and kind of build some walls.
I think the more that we're hearing is exactly what you're saying, is that the plastic surgeons now are wanting to do more of the plastics are, can't speak for derms, but the plastic guys are wanting to do more of their own injectables. And
dermatology is the same.
is it?
They're having skincare clinics and coming into that injectables and
So I
desiccation.
see that as that kind of started a couple of years ago at the society meetings. Is that the physicians were standing up saying, why did we have the estheticians doing this? And look at the complications. And they would put up on the PowerPoints all these horrendous
Right.
things that happen to people's faces.
Because we only have 1,200 hours of training. I mean, you're looking at somebody who's gone to school for 8, 12 years. Plus,
Right.
I mean, it just,
Right.
I
And
just
so
don't see
you're thinking they're going to take a hard
listening
stand
to
on that?
Well, I don't know if they're going to take a hard stand on it or not. I still think it's like you said. It's the medical board that would have to come down on it. And when it comes down to the taking the money out of the pockets and stuff, that's exactly
Well,
what
and that's
happens.
the reason that plastics and derm are moving more into the skincare is because there's money there and they're not doing as many procedures and
Right.
surgical procedures as
Right.
they used to. So
Right.
they're looking for other forms of revenue, and that's
Right.
how they're finding it.
Right.
Because that's what's become more popular than
So the
surgery.
issues I've been thinking about, listening to the dialogue over the last several months with the folks that are around this table, is that there's two ways to do it. We harden our position as we are and define it more graphically, even define it more clearly. Or two, we adopt a process which we say we can be a feeder industry for certain kinds of services that what we train is not sufficient to do those services. So therefore, if you want to do those services, that we would adopt a minimum training standard that says you have to have this training at these approved schools or whatever, and that becomes an endorsement or becomes a second-tier license. And without that, you can't function that with those and keep your license here. You have to give it up. So that's where I was coming from, is what I call the endorsement process that I saw in my head. The trouble is that's quite complex to put in final position because you've got to have so many agreements from all the different players. So we have the least power of most of them because we're not seen as the big board that deals with that stuff. But we do get influenced by it daily. So the issue is I don't know what the right answer is, and I don't know if hardening up our position is the best way. And then until the medical field agencies actually make a call, we have to sit and wait. We could take a lead role, but we're much more vulnerable to being criticized as tromping on their feet and in their territory. Some doctors that are in the particular field are going to really like the idea, and others are not. And the trouble is,
Well, and I think that the licensees who are working in in that capacity are going to object. Like
course.
here, we're governing their license, and I think they're going to rise up against us because
But what are the numbers?
I think that the numbers are growing. I think
In physicians' offices versus the medical spas?
I just think it's both. I think the esthetician is finding that
I
the
gave you the number of
marketplace
estheticians,
is
about 3,000.
the
Yeah,
marketplace is
36,000
a little restricted to facials.
And we got about a third of them.
But when I'm prepping you
I don't know.
for your surgical
I mean,
procedure, you're much more inclined to have a facial with me. So now, as a licensee, I'm highly motivated to go to work in a physician's practice because my own clientele is drying up because of whatever, economic reasons or whatnot. So I actually see it as a kind of a significant problem. And did that Allison call you that called me and I gave her your number? I had an esthetician call me the other day because I guess one of our inspectors went into her shop and reprimanded her for dermaplaning. And then she called me to say, well, who are the flaky people that told me I can't dermaplane? I said, well, that's me. But then I tried to explain to her, it's like, this is what I brought up, is like the first indication that you shouldn't be doing that is because you're using a scalpel.
Right,
And
as
that
a
didn't even
doctor.
occur to her. She just says, well, I went to the training.
Yeah.
And she's got her little dermaplaning certificate. She just can't figure out why she can't do it. And then who, in their right mind, restricted her from doing that? So in a way, that's what I mean by the licensees are going to be the attack dogs when you come up with your position paper.
But if I may, it's not just licensees. I have to regulate 6 out of my 10 SD students that are, okay, when I'm done with this, where do I get my medical esthetician license? It's an assumption in this whole industry now that my next step is working for a doctor.
Right.
That's a given.
That's what they think.
I'm going into the doctor's office because there is very few successful independents anymore because the doctors did start taking over, 6 to 10 years ago, slowly work in the industry to utilize, low-paying SDs to do their high returns. So
How to get on.
I have to, no, there is no medical esthetician in Nevada. They're going to Arizona then for that and coming back. So
Right. Well,
they're going to get something that helps them.
They had a training here a while back, and Dr. He's not working anymore because of neurological problems, but Markman was teaching it over at Euphoria School when they first opened over on Eastern years ago, medical status.
Oh, wow, I remember.
See, the industry wants to expand with or without us. That's what's going on. And it has to do with money. It has to do with either earning more money or improving particular establishments' ability to draw customers and get more money out of people. So that's the battle you have to fight. The issue is until something really catastrophic occurs, they'll keep doing it. Until somebody gets sued for a couple of $1 million
Right.
and people realize, oh my God, they're talking about what I do.
Yeah.
I mean, that's how you change it.
I'm just thinking out loud here, but if we took a hardline stance and what our estheticians do and push that out to the medical board and to plastics guys, in addition to that, having the Board of Nursing address the medical board, and then we did have an advanced tier after that says, okay, well, if you want to proceed, this is what you're going to have to do. That way, there's both options there. We're taking
Right.
our stand. And we could also say, if you're working in a doctor's office, we will be regulating you, and as long as you're using the word esthetician.
Yeah, well, we need the doctor's medical board
But-
to
but
support
the-
Well, I
it.
think Vince is saying
Why?
that. He's just saying how complicated
Why
it is
can't-
to get there. Sounds real simple when you say
But
it's
wait a
not.
minute. I know, that's what it says. It's so easy.
It's so easy.
I
Well, the
know.
doctor
It never is.
won't want the inspector.
Why? Well, then they'll have to be under the doctor's licensing as an MA.
But that's what we have it.
In-
Well, that's fine,
Enforcement.
but then they lose their license
But
if they practice.
it's much better if we have the support of the Sport BMA.
Yeah, if we don't have the Board of Medical
And the nursing
Examiners
board
agreeing
also.
to it
Yeah.
as
I think
a
they're with
concept,
us on
But-
that.
kiss it
Yeah.
off.
Simply stating that if
Public
you're going to
safety.
work
Yeah.
using the esthetician
The
licensing,
first challenge, Jeanette, is going to be they come under my authority, not yours. Under my license. That's the
fine,
argument
but then
they use
can't
now.
go back into aesthetics.
And
They can't leave the
And so the
practice.
person, we can't do a thing about it, so they work there another 2 years, then they quit, and they go back into aesthetics. In the meantime, the only thing we can do is take their license and start them all over again when they come back. If the board wants to go through all of that, that means going to be a lot of hearings
Yeah.
and a lot of challenges, because they're seeing that as their right.
I feel like they've earned that license. Now that they may be misusing it, that's one thing. But all I have to do is tell you, hey, I'm going to keep paying my license fee. I just won't call myself an esthetician when I'm working here. I'll just call myself, hey, I am a licensed esthetician, but I'm not using my aesthetics license when I'm doing whatever
And that's
I'm doing
okay
to you.
with us now. That's where we are
That's
now.
exactly. That's where we're at now.
But I
We
don't
already
think
have that
that's-
definition.
I don't
That
think
doesn't change
that's
anything.
safe.
Remember when we started this discussion, there was this interest in expanding the capability of the profession.
Right.
And we've now begun to roll a little bit about, that's a lot more complex than we thought it was originally.
Yeah.
But there's going to be advocates and there's going to be unadvocates. I look at from what happens if Sally Smith violates the rules, where are we going to catch the heat from? And sometimes you don't have any idea where it's coming from. But the first one I spotted was the cosmetic surgeons and the doctors who are medical doctors are trying to use that leverage to build different kinds of businesses for revenue streams, cost centers. And I see that's a good business position, but they've really not analyzed the risks that are involved until somebody has the problem. And so that's where we stand right now. And I don't know if there's a solution. I can't figure it out.
What about going to the malpractice carriers
Right.
and asking them? Because
That's a good idea.
Yeah,
The
I
best
can have a
way-
rep from one
Great
our
idea.
next meeting.
Yeah.
He was an
That's-
attorney, my friend Chris. Up there.
and to
Yeah.
tell them what problems you're having and what your concerns are, because they're very interested in that kind of stuff. And if it's a risk they haven't calculated into their malpractice premiums,
will.
like the HCG, they'll handle that all on their own. They'll decide they're not covering it, or it's a high risk behavior, and that the physician has to pay more if that's what they're doing in their office. And that changes a lot of
That
things.
usually changes. We had the topic that, I don't know, you weren't there at the time, but the surety bond issue is that way now. The trouble is it doesn't do anything when it expires just before it's needed.
What's
They
the
let it lapse.
surety bond?
Surety bond is they put up, we require schools to put up surety bonds to protect the students' contracts. But if they're going bankrupt and they
Yeah.
lapse, there's no money anyway,
Yeah.
so you're screwed. And so we end up holding the bag every time.
Sure.
So the issue with this is we don't want to have our industry be, like you said, accused of not doing what we're supposed to be doing. That's one. The second is we don't want to inhibit other professions that if they're willing to take on that activity, that we can, if we can agree on what kind of training these people need, that we can say if you want to be one of those, then this is what you got to do, period, and go to the legislature and have them pass it for us. But I've not been able to get even interest in people coming together and say, let's argue about this, where we draw the line in the ground.
Here's the other component too, which is as a licensee, I want to be considered for employment before this person
Exactly.
who's not licensed.
Exactly.
Because I
Agreed.
devoted a little bit of money, a little bit of time, I put in my sweat equity. So when I go to apply for that MA position with your medical practice, I do want my license to say that I'm a little more skilled than this other person.
Right.
So in a way, I don't want to lose that credibility for employment opportunities. But that, that's not our place. David constantly tells me we're not here to create business. We're here for safety, always public safety. But the reality of it is, I don't want to create something or be a part of creating something that inhibits the functions or the expansion of these businesses. Like it doesn't behoove us as a profession to tell a physician, hey, don't hire these estheticians for this low-cost labor pool, when really that is an employment opportunity for a lot of these low-cost labor pool licensees.
That's what I was thinking. The insurance carriers may not be aware how much of this is going on. And sometimes when I was a vice president of a children's hospital, I dealt with medical affairs, and I would often talk to the malpractice carriers about new things that were going on or problems I would having, and they'd be like, "Excuse me, what's going on?" And they would start taking notes because they were not aware that physicians were doing certain things, and they were extremely interested to find out the risky activities that were going on. And then they could decide, as an insurance carrier, where they felt that fell in terms of risk, how many people were doing it, and what they wanted to do about it. And sometimes they were very persuasive at slowing down questionable activity. And that way it doesn't come from you, it doesn't diminish business opportunities. It says maybe you all ought to be moving towards the licensed people because that gives them more protection. And that's why physicians consider licensure the gold standard, because it's more of a protection. Look, I hired somebody who was licensed. I even trained them and helped them train, and I kept them under their license. And what they did isn't outside of their scope of practice. Then, if they get sued, you're looking more at complications, side effects that sometimes happen, not somebody who should never have been doing that in the first place. And that's a much better argument as a plaintiff's lawyer. You shouldn't have had this person doing this to start with, versus I had a licensed person and something didn't go right. A little different.
And then to coincide with that, it's the same thing with the registered medical esthetician. It's like, as a licensee esthetician, I feel I'm no less qualified than somebody who went through a registered medical aesthetics program. So do you see, like, I know, odd, huh? So in a way, now all of a sudden I'm competing with somebody in the workplace for what I would consider an equal skill set, but they are carrying this little extra,
And
vernacular.
And the employer doesn't know what it means.
Well, yeah, it can't distinguish between the two. And yet, which one of us really shouldn't have been hired to do that type of
I
activity in
can't
the
find
first place?
anything else.
Yeah.
Yeah, very
Oh, you
curious.
can get emails.
Yeah.
You want them?
I
Yeah,
would like
Sure.
especially you two, because we have to get back to you periodically.
That would
Just
be
because
so
you have
helpful.
some opinions that are critical to us from the medical side of the equation.
Yeah, and I think we need to see if we can get somebody from the nursing board and the board of BMA.
We do have I provided that information.
Yeah, we're in the gathering of information scope. I don't know where we're going to end up with this thing because it is complex. I've been here almost 5 years, and I started noticing in about the start of the second year, and I have not seen any real solutions. I had high hopes for the nursing board regulations and the medical board regulations, but I think we just sort of took away little problems, but not really solved the bigger issue. And I don't know if it's the state, the culture within the state, is it the primary beliefs by the legislators and don't want to get involved in that, or if it's who you know rather than what you know kind of tone of how we negotiate these things. There was a lot of that went on recently, though, in the last, I'd say, 2 years. A lot of negotiation of the big players in the business who don't want to do it, and they either advise or sit on the medical board and the nursing. The nursing board, I know, sometimes goes like this with the medical board. I sense that fight going on because of determination of our definitions. I don't want to get us into that level, but I would like to be a facilitator of something to move it forward. I want to thank you for your participation. You've been very helpful. And I will probably call on you again in the future to tell you, what does this really mean to me? Can you say it in plain English for me?
Well, thank you for inviting us.
Yeah.
And if you have somebody that you think we should talk to get another perspective, I'd really like to do that, invite them to meet with us.
At the board, one of their attorneys at the board that I always call, and she's very good, is Lynn Beggs. Have you heard that name before? She's incredible,
And she's an attorney?
She's an attorney for the board. So
The Board of Medical Examiners?
Yeah.
Or board of nursing?
No.
Board of medicine?
Uh-huh.
Oh,
Yeah, I
cool.
call them a lot because I
Sure.
work in a physician's office. The only things I do with Board of Nursing is looking on the website at what we can do and what we can't do. Because I know they're always doing this.
And who's up for getting their license revoked?
Exactly.
And for what?
Exactly.
Yeah, I remember talking to Louis Willing, who was general counsel for the Board of Pharmacy. I met him, and then he became the executive director of the Board of Medical Examiners. He got thrown down.
Yeah.
From my perspective, I'm an outside looker looking in. But that's what this issue was all about. Because he and I had talked, and we had a lengthy discussion, and he says, well, I'm setting the stage for that kind of dialogue. Next thing I know, he was unemployed. It was that quick.
Yeah.
And so this is a touchy issue for him, because the Board of Medical Examiners, board members are mostly physicians, and they objected violently once the heat started.
For the physicians or hospitals that you've worked for, have they utilized licensees from other professions as as an entry? Like how you were able to earlier distinguish between, well, look, here's a person that had some skill set, and this person should never have been doing anything in the first place. Like you made that distinction. So have you encountered that type of?
Oh, yeah.
Oh, okay.
And that's why, to them, licensure is the gold standard,
Okay.
because it means a board is regulating you and there's some rules.
Okay.
The only problem, and you raised this, is the people who don't want to have, who are just looking for the cheapest option, those are the people who are
That
going to
could be
skirt
very
the
vocal.
issues. The people who really want to do a good job and who are concerned with their quality are the ones who are very concerned about the licensure and are usually following the rules, in my experience.
So in a sense, what I hear you saying is almost that's
Reno.
that's an argument for a second tier license, where we have our standard license, but then we have this second level of license that makes it a little easier to interface with that medical community. Not so much our first tier, but perhaps a
Right.
second tier with
And
a
those
few more
would be the
select
people
groups.
who would be your medical estheticians,
Yeah,
or whatever word you want to
The
call it.
way I
now.
envisioned it when I was talking to Jeanette privately is, as a feeder profession, that means that if the Board of Medical Examiners could tell me what are the minimum standards that they should be meeting that are good standards that they should be, we could say, if you want an endorsement or a second tier license, this is the training that must be taken, and you
Right.
cannot be certified by us until that's done. That leads back to the gold standard. That these people are licensed by another board, that we agree with their standards,
Right.
and therefore we can accept them. Then we don't have a problem them working in those kind of industries. It's not cheating any longer. We now are convinced that they're properly trained.
But then the reality of it is coming back to what you said earlier, is look at your malpractice companies, because now you're going to have to ensure that tier.
Well, the doctors, if they want to, even if they have them working for them, if they're working in that shop, we can say, you still are working under the doctor's supervision,
Okay.
but you can't work in using the aesthetic license under any condition unless you meet these minimum standards.
Right.
The second tier, much like the nursing board is trying to do now with their regulations.
Well, like I'm showing Sandra, and I think you gave this to me, Alex.
Yeah. All right.
It's moving forward. So
Oh, yeah.
we either
Well, these
something
folks,
about it.
I think these folks are violating everything we stand for, because they're doing exactly what they're not supposed
it's
to
a
do.
school in Reno, and it's telling you advanced aesthetics and then medical aesthetics.
So they
And they were
really,
teaching it.
They've
And then
really
that's
made it
gonna-
very
Is that at one of
complicated.
our schools?
That was
Right
that
now.
little magnet that I gave you the last time from the
I
meeting.
don't remember.
It was that. Yeah. It's,
But yet
It's already
there isn't
happening.
any license that
She was
No.
saying.
Yeah.
No,
there's
It's
no.
just like one of those.
They get their certificate.
It's
They
just like what I was
expect
saying
their
with the
training
physicians.
for it.
They go to a weekend course and then they.
You know why? Because my lady, you know the book, the brand that
Milady's
my
got it.
lady has. They have two different books. They have the regular aesthetics, and then they have the advanced
Advanced.
I
training.
think I have a copy of the advance.
Exactly, and if you read that one, because when I had to substitute for it, I'm like, I'm not governed to teach this. So I took it to my boss. I said, this is a whole different license here. This is a whole different license.
And that's what's occurring. These associations are convincing the textbook people that this is where we're going, so they're trying to get ahead of the
And
game.
absolutely, it's going to go there. It's coming.
They're
It's
forcing us.
coming.
But then, from a school perspective, I mean, just out of curiosity, where do you see the school? Like, do you want to start
Well, some of
expanding?
the schools that are in states that are licensed under a doctor for, say, the laser, they're starting to roll that out, because that is
Roll it out, yeah.
that's where this industry is taking them. So as soon as the regulations change on the state level, they'll move into each state that opens that up.
But what they're doing is marketing into those states already, trying to convince people to bring the topic up.
Bring it up. Right.
Yeah.
Right.
And so you see it in some states. The first states that do it open the door for the rest of them to be compared with. So that's what's going on. And it's a marketing game. It's a
Right.
political game.
Right.
So you're saying that this is the direction. So hey, come on board now. Get your textbooks up to date now, because in 3 years' time you'll be on the upper end of that bell.
Yeah, that's what's going on. So
Yeah, that's
what you're really seeing is marketing and politics mixed together at the same time. And when I bring it up, most people get angry at me because they don't see what I see. I live in her arena. I always see I used to be the chair of the oversight committee for all the hospitals in San Diego County, from the county for all indigent care, Western world. So I understood all that language. I knew what they were talking about. So that's what I see coming. When I try to explain it to schools or other people, they have no idea what I'm talking about. But I've been through it. I've been through it with hospitals on a couple of $1 billion budget every year when the county has to dissipate all the money out there. So that's what I see coming at us. I don't know when it'll arrive, but I don't want it to be an endoscopy kind of wake-up call. I'm trying to get ahead of it before it hits us. David and I has heard my speech a number of times about what we need to do to try to get the dialogue on the table, get the reputable people who actually know what's going on with us, so we don't assume things, and then from that we can start planning on what we're going to do about it. Maybe I don't have any idea as to what I would recommend at this point, whether it be a hardline or. I see it. Nirvana is when we have the right kind of second tier that the Board of Medical Examiners and the Nursing Board can say, well, we agree with that. We can live with that. And then we all have the same line in the sand that we can match up against. I don't want to do anything that upsets the Nursing Board. I don't want to do anything that upsets the Board of Medical Examiners.
But a good point, and the insurance companies to see how what they're going to.
Well, and like she said, they may not even be aware that,
Right.
this
That's
is
another
even
alternative.
really
That's
That's a good suggestion.
But if we propose something, shouldn't it be done by next August, right, to go into?
No,
Yeah,
it's got to be ready to go in January of 2012
Which is
for a law change.
Well, because it would have to go to the legislator before June 30th. Because
Okay.
Yeah, it goes to.
and then that's for the
cycle
January
is
of the
thus.
following
We
year.
just finished up the current cycle in 2011.
Right.
We have to have any bill we're sponsoring by January 1st, 2012, because the governor's office has to approve it by May something to go that it comes out of his office. And we were supposed to come through his office. When we don't do that, then we have another year, but we have to find a legislator who's willing to carry our legislation.
Yeah.
That's why it takes so long.
Right.
It's a 2-year cycle constantly.
Right.
So the issue for us is can we accomplish what we think might be worthwhile doing between now and January 1st? That's the real issue. Otherwise, you have to wait another 2 years. Or build it into regulation. Maybe you can change the regulation that would allow us to go faster, because that's on the off years, the Legislative Commission operates, and that's who approves legislation. But you've got to have some authority to do that in the NRSs, the Nevada Revised Statutes. If you don't have any authority there, you've got to do that first.
Right.
Then it becomes basically a 3-year cycle. So those are the kind of issues you run into. We've been talking about this. We're starting to get some stronger feelings about where we want to go, I'm sure. But we're now beginning to see what are the downsides, what are the issues that are going to get in the way, who we got to convince to participate in the dialogue. And at least say, the theory you use is neutralizing the naysayers. What that means is you get the people who are against it to shut up.
Right from the get-go.
All right, you say, look, this is a good idea, and they say, well, it's not important enough for me to bark. So they stay out of it. So now you neutralize your opposition. Once in a while, they come out of the woodwork anyway, because they don't understand what the issue is, and they cause trouble. And then you have to repair the trouble before you can move on. So that's a very complex system that operates.
glad it's you, not me.
Thank you so much. It was really nice to meet
It
you.
was nice meeting you too.
I may want to
Nice
chat with you guys
things to say.
independently to get a better feel for
Very
what you said and what that means to us.
Okay.
I think
A lot of-
the
I
legal
learned a lot of
standpoint was
stuff.
excellent.
Yeah,
Me too.
Yeah, 'cause it really was helpful.
Awareness. I mean,
A lot of people,
And
a lot
I
of
think
people,
Thank you for letting us
Oh,
say
you're
that.
welcome.
Appreciate it.
unknowledgeable people that are out there.
a lot of
I
people
don't
have never been on the
Nevada, so I don't know Nevada law that well, but.
Me neither. I was out of California, so I know. I used to run with the guys and gals that did the Supreme Court dialogue. So I've been there a number of times. The worst case, I've been to the Circuit Court of Appeals twice.
So this is
Yeah, and mine are all use of force and deadly force. If you kill somebody now, I had a dog barking, a dog biting case. That was the standard for the nation. No, they were trying. An LA firm was trying to kill dogs in law enforcement.
Malpractice.
We'll get some.
Do I need to, we need to end that meeting?
I want to end this meeting at 11:57. Thank you.
So if we want to have more meetings,
Yeah.